Hello, everyone. This is Chadderdon from CVI 2025 in Austin. I'm really privileged to be with Dr. Scott Chadderdon to talk about the role of invasive imaging in structural heart. It's very important, Scott. Thanks for joining us.
Well, thank you.
And without you, there's a lot of procedure cannot be done. So, where are we now in terms of invasive imaging for structural heart?
I think we're a little behind the eight ball as far as developing imagers that one kind of have the skill and two that want to go into this practice. I think it's a little intimidating at first as an imager. We're comfortable in a dark room in a lab, and we have like a stack of echoes to read, and ask people to jump outside of that, take their skills into the cath lab, reintroduce fluoroscopy to them, as well as other imaging devices. That can be a challenge. So we need to find the right individuals that are looking for not just imaging, but I think what is more of a teamwork of approach where their ultrasound and their imaging skills can really come to life.
Yeah.
That's what I see this as.
And Scott, I think from your experience, you learned the skill in the practice. You didn't
Yes.
have dedicated training.
Yeah.
Now we have some program where they train people for invasive.
Yeah.
So do you think this is necessary skill to have if you want to sign up for such job?
I really think that having additional structural and interventional imaging is going to be key. We're seeing so many different devices being developed. There's early stage, then there's pivotal stage, and then there's commercial stages of devices. And having a basis of those in a training program will help you so much in jumping into a practice, whether you're an academic practice or if you're in a busy community practice that has access to commercial devices and or being involved in research trials, because there's that as well. But the more access you can get around the delivery of different types of mitral tricuspid, left atrial appendage, or even the newer heart failure, interventional heart failure therapies, the better poised you are to go into a practice and make an effect and a big effect on patients' lives.
I spoke some to the people practicing as well as people are in fellowship that they are worried about going into invasive because they are worried about their productivity when they go to the job. Because you can spend sometimes 2, 3, 4 hours in a case, and while somebody else in the echo lab, as you said, like click, 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 is cracking echo.
Yeah.
So how you reconcile this, and what's your message for these people, and how they can choose their job wisely if that's their passion?
Yeah, I think as you're going out and you're looking for a practice, you have to find. I don't think there's one solution for everyone. So an academic practice may be completely different, where you're salary based, you may or may not track RVUs, but there's a bigger system to help support that. In other practices, there is, reimbursement and resharing within groups to then help support those providers. If you're on an RVU practice only, then those imagers will not be compensated for the degree of skill or what they bring to the table for a heart team. When one person gets 4 RVUs for a procedure and another one gets 34, there's a discrepancy there.
The same amount of time.
Yeah, and it's like, well, we're all involved in it, and there are ways that people can sit down at the table and administrators can sit down at the table and figure that out. So it's not a one size fits all. I think there are multiple solutions out there.
And CVI is more into innovation. So one of the things had been highlighted during this meeting also wellness and safety from radiation. So do you have a certain protocol when you are in the cath lab for your safety from protection from radiation when you are in a long tricuspid or mitral valve case?
Well, I think, again, that's the practice of your cath lab. So I think there are some standard things that we do. I think it's becoming more and more recognized that we need that. I think the beauty of the procedures now is that the fluoroscopic guidance has become lower and lower as you become more proficient at those cases. I'd like to see, investment in not just echo-based or anesthesiology-based radiation safety. I think radiation safety is for everyone in that room. And so while we're at the head of the bed, there are other people at the head of the bed that are just as important. We're not in the cath lab as much as interventional cardiologists. So while they're not at the head of the bed, they're in there 4 to 5 days a week. I'm in there 2 days a week. So even though I might get more exposure at the head of the bed, the cumulative radiation is an issue. And I think system-wide and lab-based things should be focused on that.
Yeah.
Like, it shouldn't just be, well, the imagers need it. I think the room,
The whole thing, the culture.
the room needs it. And like, so if there's a way to shift that process, everybody's voice elevates instead of just saying, well, the interventional imagers, why do they think they're so special?
Yeah.
Right? Or the cardiologist.
How about the
thinks
nurse
they're
within the
so
cath lab?
special.
How about
But
the
like
technician?
there's the nurses, there's a technician, there's
Absolutely.
like all of that has impact in longevity and quality of life.
Absolutely.
Yeah.
Well, Scott, thank you so much for your time.
Yeah,
And for
thank
giving
you,
us an
Chatty.
insight on
Yeah.
a great, a role of invasive
Yeah.
imaging in structural heart.
Yeah.
Watch his videos and others on CVI YouTube channel. This is Chadderdon is coming to you from CVI 2025 in Austin.